Okay, ladies and gentlemen, on behalf of the Pakistan Society for the Study of Liver Diseases, I welcome you all on this webinar on liver transplantation under the corona epidemic. First of all, I would like to thank all the distinguished guests and speakers who have been my mentors in the past, except Professor Firia, who has been my colleague. Thank you very much for taking some time out and educating us on this topic of liver transplantation under the epidemic. I mean, epidemic has actually changed the way we live, and we are still struggling to find the way how we would carry on as clinicians. And since liver transplantation is very intensive, majority of the patients are already very sick. So there was a discussion in the early part of the epidemic whether transplantation should be carried on or the programs should be put on hold altogether. But now I think slowly and gradually, most of the transplant programs are resuming their activity. And since we have to make some changes under the circumstances, the way we practice liver transplantation, and that was the whole idea of organizing this webinar, to bring the experts and the leaders of liver transplantation and have a nice discussion for 40 to 50 minutes. So we will have three speakers. Each will have 15 minutes, and then we'll open the forum at the end for questions.
Yeah, I'll do that.
So we'll formally start with this prayer that all of you remain safe and blessed under the circumstances. So it gives me great pleasure to introduce my first speaker, Professor Ruben Firia. He is a liver transplant and hepatobiliary surgeon in Cordoba, Spain. Me and Ruben used to work together at King's College Hospital under the mentorship of Professor Muhammad Rela and Professor Paolo Muzan. So it is all a team from King's College Hospital, but actually none of them is working there anymore. And all of them are working in different hospitals, running their own program. Ruben Firia has been a great academic and was very fond of research. So I'm pretty sure he's going to bring good stuff. And sadly, Spain has also suffered a lot in the epidemic. So Dr. Ruben Firia is going to speak on the global impact of COVID pandemic on the liver transplant activity. So hand it over to Professor Ruben Firia.
Thank you very much. Thank you very much, Professor Dar. Thank you very much for the invitation. I feel very honored to be sharing this webinar with you, who indeed you were not my colleague, you were my mentor as well, and with Professor Rela and Professor Muzan. So let me try to share my screen. All right, so I'll give my talk about the worldwide impact of COVID-19 on liver transplant activity. And this is the situation today. It's more than 6.5 million cases, almost 400,000 deaths. And these numbers are huge. And also the numbers are huge in terms of research. As you can see in the figure, since January, almost 20,000 papers have been reported. So it means one manuscript every 12 minutes. So it's a huge amount of information. Since I got the information from Professor Dar, I screen literature every 2 days. So in the last 2 weeks, more than 50 papers have appeared regarding liver transplant activity and COVID. So I will make my best to give you the most updated results, but I'm not sure whether in 2 months with 200 papers more, this will be outdated, but I will do my best. So certainly there has been a reduced transplant activity. And I think that the 4 pillars in which it has based is first, we did not know how to test positivity on donors. The second pillar where we were all concerned about the safety of our surgical teams. Third, we did not know the impact on the outcomes of our recipients. And fourth, we were unsure about the availability of ICU beds. So starting first with donor positivity, it doesn't matter what meta-analysis you go for, what study you go for, you will find out that sensitivities, even though they are high, the confidence intervals are not that good. So this is the real situation in a population with 80% positive cases. What you will have is that almost 56 will be positive, but this is the real situation. The real situation is that there will be about 15 to 20% who will be false negative. And we were all concerned about that in the early terms of this pandemic. So we have learned about test, and retest. And even though we were sure that the patient, even if we have a negative test, we knew that clinical suspicion was high, we should retest. What was the second factor that I think that had a huge impact on transplant activity? The safety of surgical team. Thousands of healthcare providers have been infected by COVID-19, and hundreds of deaths have been reported on doctors, nurses, and healthcare. At some point, this appeared in the Spanish journals, that healthcare professionals went to war without protection. And that is something that we were concerned in the early times of this crisis. We did not know what would happen if you sent a surgical team from a region to another. So I think at some point, this had a huge impact on liver transplant activity. We learned some lessons from the Taiwan SARS syndrome, and I think that this will come in the future for our hospitals. Our hospital, since this crisis, will for sure have quarantine wards, transition areas, isolation areas, and everything will change since now on. This BMG opinion happened 5 days ago. The widespread of COVID-19 infection among Spanish healthcare professionals did not occur by chance. So we have learned that health system fragmentation was not a good idea, that we need more investment in healthcare, and we need proactive strategies for tracing contacts. And I think that at some point, this had a real impact on our transplant activity. Regarding the third point, what was the impact on recipient outcomes? I think in the early phases of this pandemic, we were also concerned about this because we did not know what would happen if we transplant a patient from a COVID-positive donor, or what would happen if the liver transplant patient would be infected by a COVID. So I don't know what is this. So we know that, I don't know what did this appear here. Okay. So we know that this has been published in Lancet that if you operate, this is not on liver transplant population, if a patient's diagnosis of COVID undergoes an operation, 51% of them will develop postoperative pulmonary complications, and mortality will be about 40%. Several risk factors have been reported to increase this mortality, but the conclusion is that postoperative complication and mortality is higher than in the pre-COVID era. So surgery should be postponed, and that's something that surgeons kept in mind. We were all trying to not to put patients on risk, and we were trying to postpone. So what happened in liver transplant recipients? I think that Professor Muzan will give you a lot of information about this, but I will tell you that in the early phases, we were really concerned about the fatal outcomes in liver transplant patients because they are immunocompromised patients. And so far, the severe cases of respiratory infections were being detected in a high mortality. But results are not conclusive. In some series in the States, you can see increased severity, and increased mortality in liver transplant recipients. On the contrary, 5 cases from the United Kingdom, from Keynes, report the contrary, less incidence, less severity, and mortality. In the biggest series reported today is a courtesy from a colleague from Spain, 111 cases. It can be reported, it has been reported a decrease in mortality. So at some point, the impact on recipient outcomes in the early phases was not clear. Now on 2 or 3 months after this pandemic started, now we feel a bit more comfortable with the management of COVID-19. And the fourth pillar, and I think it's really important, what was the availability of ICU beds? Well, I think that two things can be, it was based on two main issues. First, the ICU beds were overbooked with severe respiratory to COVID-19 patients. And the second concern was, I think that we were all concerned about mixing COVID-19 patients with immunosuppressed liver transplant patients. This is an interesting study. It was done before knowing how all this pandemic, how big this would be. You can see it was made by a group of Spanish statisticians, and this was the expected availability, the expected needs of ICU beds in Italy and in Spain. And then this was the current number of ICU beds in Spain and in Italy. So it really, the numbers were expected to exceed the number of available ICU beds in both countries. And this is the situation in Italy. These are the number of ICU beds that were needed within 1 month. And in 2 months, you can see the situation of collapsing in the liver transplant programs, in the hospitals, and in the healthcare in general. What happened in Spain? This is the picture. This is a 12 days picture. This is the 10th of March. This is the 22nd of March. And as you can see, the situation in Madrid, the number of patients who needed ICU exceeded the number of available ICU beds. So this definitely, I think, from my point of view, was the fourth pillar. How could we do a liver transplant in an ICU dominated by COVID-19? Well, these points, I think, they are important. We need to increase the number of ICU beds by using recovery areas, by using theaters, operating rooms, or whatever. We needed to divide COVID positive and negative sectors, test PCR, transfer between ICUs, between regions, and use different circuits. So I think that these 4 factors are the main pillars who caused this, a reduced transplant activity. And what was the result? This was the result in France, for example. This is a paper from last week from Lancet. You see, as the number of COVID-19 patients increased, the transplant activity decreased. Same thing happened in the States, although this drop was not that remarked, but similar thing happened. This also happens in Netherlands, a sudden drop in total organ donors, total organ transplant, and a drop as well in liver transplantation. And what happened in Spain? You know, Spain is the country in the world with the largest number of donors. And at some point, the 12th of March, the government dictated a national alarm. So everybody should stay at home. And suddenly there was a huge drop in the number of donors. Not also in the cadaverics. There was an absolute stop of living-related liver transplants. And as you can see, that's also what happened with the liver, also with kidneys, and of course, with all the transplants, just a few heart transplants, few kidneys, but the drop was really remarkable. I'd like to remark these two sentences from this manuscript from Sharma et al., which I think is important. Although pragmatic, there was a disproportionate resource allocation to COVID-19. We can understand that. It's obviously, it's easy to understand, but this definitely led to a health inequality. And although difficult decisions were being made, there was a disadvantage to marginalized patients. And I think that our liver transplant recipients were at some point one of these marginalized patients. There have been several scores which have been reported. I'd like to mention this score, the MENS score. It's a score in which not only using resources for COVID-19 patients, we have to consider a whole picture. So procedure factors, disease factors, and patient factors have been taken into account to create a score, a decision-making and triage, in which a cumulative MENS score, if you have a higher score, you will have poor outcomes, increased risk of COVID, and increased hospital resource use. And at some point, we had to decide whether it was okay to proceed because the whole picture was favorable, or we had to consider that the procedure was not justified. Paolo will talk about this in the future, so I will not talk about a lot about this. But I think it's convenient to put the focus on the fact that liver transplant was just not a matter of stopping it. We had to consider several issues, including healthcare resources and waitlist mortality, just not to stop the liver transplant products. So what is the situation now? I think we are getting better. We have overpassed the first wave. Probably most of the countries are now or will be in the near future in the second and third waves. So we are definitely getting better. But at some point, I think we are getting much more confident, and that we should be cautious on that. We should be cautious on that. I will come later on to this point. But however, although we have seen a whole picture of decrease in transplant activity, there were some areas in which this did not happen. I'd like to put the focus on a couple of samples. This is a manuscript just released from the situation in the States. This is the picture in 2019. You see, in 2019, the more donors you had, the more transplants you performed. This is the picture in February and March 2020. The less donors you had, the less transplants you performed. But at some point, some areas did not follow that correlation. Some areas had a drop in donors, or maybe not, but they kept on doing their liver transplant activity. And you can see there were 4 areas in the States which did much more deceased donor liver transplant than what would be expected according to the previous year or to the number of donors that they were collecting. A similar thing happened in some areas in Italy. In Italy, some areas guarantee liver transplantation by using some policies that I think that were the same, but in the state: dedicated free COVID-19 pathways, dedicated ICU beds, special COVID-19 donor recipient protocols, real-time PCR and CSCT, and of course, an informed consent. And why I said that we are getting more confident and we should be cautious of that, because some people, some manuscripts are talking about using SARS-CoV-2 infected donors. Some are not. I think it's not the point to consider that. After the years we have used HIV donors, we may use them in the future, but probably now is not the situation. I think that we should be cautious on that. I think the key point is to make individualized decision-making regarding transplantation. There's a risk of donor-derived COVID transmission, lack of therapies for treating it. There's a possibility of severe COVID-19 disease post-transplant. So we should have a honest discussion with the patient and with our team about the risk of death on waiting lists and consider individualized decision-making decisions regarding the transplant. I would like to use my 5 conclusions just to show you my last slide. The blanket refusal of organ offers due to uncertainties about COVID-19 transmission, it may increase mortality in vulnerable patients. We must remember that our liver transplant recipients are vulnerable patients. Organ transplantation remains a vital life-saving component of developed health system. We must not forget that we stopped and we dedicated all our resources for COVID-19, and maybe that we should have thought about that in that moment, or for sure we will have to think it in the future. Sick patients are worthy of the utmost care. Transplantation supports social cohesion as it begins in an act of altruism. We should adapt to emerging knowledge. And of course, we should have said before, individualized decision-making. This is my last slide. I think that liver transplantation in the era of COVID-19 is different to the pre-COVID era. We should consider surgical strategy, indication, donor risk and care. We should take special cautions in recipients, in post-op care, ICU care, and of course, consider drug-drug interactions when we have reliable therapies. Thank you very much. It was a pleasure to be here.
Okay, thank you very much, Professor Ubunfiria, for giving a nice presentation. I mean, that is clear from your presentation that the transplant activity has significantly reduced worldwide. But since most of the transplant centers are resuming the transplant activity, so the donor and the recipient issues are important. And our next speaker, Professor Paolo Muzan, he is a transplant and a hepatobiliary surgeon at Queen Elizabeth Hospital, Birmingham. Professor Paolo Muzan has a special interest in pediatric transplant and the non-heart beating liver transplantation. He has also witnessed the pandemic in UK and Italy. So he's going to throw some light how to look after donor and the recipient issues once we are taking the transplant activity back towards normality. Hand it over to Professor Paolo Muzan.
Thank you, Faisal. Thank you, Professor Dar. Very kind invitation. I will start straight away, and I hope that the screen is shared. Is that so?
Yeah.
So I'm just trying to produce. That's done. So my first slide. There it is. Yeah. So we heard already the numbers. Huge pandemic. 7 million confirmed cases and nearly 400,000 deaths around the world, with Italy, as you say, and UK particularly impacted. The issues around liver transplantation and around donors and recipients that you asked me to discuss today are the really requirement of the healthcare resources to perform transplantation, the exclusion of donors or selection of donors, excluding those infected with COVID-19, selecting also the transplant recipients and candidates in this pandemic time, and in looking at the particular state of the recipients, which will be immunosuppressed and have more intense and prolonged shedding of the virus, and increasing the risk of transmission to contacts, and not lastly to healthcare workers like us, which are important in the performance and management of liver transplantation. So in terms of donors, what is important is transmission. And we know that the viral nucleic acid sequences are detected in blood, ascitic fluid, feces, saliva, eye secretions, and is being found by PCR in heart, kidney, liver, pancreas, GI tract. Transmission routes, we know them well: mucosal contact, droplet transmission. There is a potential for fecal-oral transmission, and the high concentration aerosol, which is particularly important for us health workers. So it has come at some stage the question in this pandemic whether organ transplantation should be put to a halt or should continue due to the unknown risk of transplantation in this setting. And you know, one of the first articles that came in a sense reassuring came from Bergamo, from Italy, that showing that immunosuppressed individuals were not at risk of severe pulmonary disease compared to the general populations, and really postulating that a lot of the pulmonary issues were secondary to also immunosuppression modulation, and therefore immunosuppression could not have been such a bad thing, maybe even a protecting way for transplant recipients. And so there was no reason to postpone or to halt liver transplantations, but this had to really face the issue of competition for healthcare resources, which were given at the time to, or are still being given at the time to patients with COVID-19. In terms of donors, donors need to be screened to avoid potentially transmitting the infection to recipients. And it's known that there are shortages, or certainly there have been shortages of laboratory screening tests and kits. It's important to know that nasopharyngeal swabs are sensitive, but not that sensitive. We're 63% sensitive, so there is quite a number of false negatives, and even more for oropharyngeal swabs, where 60-70% are false negatives. BAL seems to be the most sensitive method, but BAL has the extra risk for health workers in terms of producing aerosol. The rapid NAT test need to be available for OPOs in order to have quick results and not to set up transplants without really knowing whether the donor is positive or not. CT, if available, is highly sensitive for COVID-19 pneumonia, but is not specific. The approach to the liver transplant organ offers by the ASLD recommendations, as you see, although it's written very small, it's just really looking at screening testing the donor and proceeding only with negative testing and screening, and after screening, calling the patient in, the recipient in, and testing the recipient, and again trying to get a quick result in order to proceed with transplantation without delay and increasing the ischemia time. So the impact, you heard the impact on liver transplantation by Professor Ciria has been really strong, and there's been limited, a high influx of COVID-19 patients in ICU beds, so taking these beds away from N-ward beds from potential liver transplant recipients. Not only, but also a lot of us has been redeployed as ICU doctors for a period of time to look after COVID-19 patients. So there's been a scaling back, or in some countries even an interruption of transplant activity. And but unlike kidney, for liver transplantation, there's no alternative to this life-saving procedure. So what has needed to be done in places with the scaling down has been to prioritize sickest patients and make a choice which is being made almost every day to put in to do a core or more urgent patients on the waiting list that are those that will be directly transplanted in the next few days. And this list should be looked at almost daily or twice weekly at least, because of course things are dynamic and fluid. Also, there is the issue of risk of donor transmission and recipient consent issues. In the sense, the recipient needs to be consented for also this added risk of COVID transmission, although there is limited guidance, because the truth is we don't know much about it. The impact on liver transplantation is clear. You can see the Roberta Angelico from Rome, a former fellow in Birmingham, has shown very early that at the 4th week of COVID-19 outbreak in Italy, there was already a 25% reduction of procured organs. And in terms of translation into liver transplant activity, this has been shown by Umberto Maggi with on behalf of the Northern Italian groups, really shown a big reduction of liver transplant activity during the COVID outbreak. And this is in spite of almost doubling of the ICU beds to allow more COVID patients to be treated. In terms of deceased donation, one issue has been that of trying to avoid the traveling of retrieval teams to donor hospitals to limit, again, COVID infection and transmission. And in very high-risk countries, or when they had the peak, there's been a temporary almost suspension or deferral of the deceased donation, or deferral of more elective transplants. Professor Rella will talk about living donation, but of course, although recipient surgery is essential, donor surgery is non-essential. A lot of groups do laparoscopic retrievals, and we know that those are under strict surveillance right now because they could cause aerosol and therefore be damaging for the health workers working in theater. And also the use of CUSA, as you can see, can, if it doesn't work very well, the aspiration can also cause aerosol and promote dissemination of the virus. The only issue I would want to see is also that a living donor need to be, again, appropriately informed with the consent that there is this added risk for of getting potentially COVID in hospital and being a COVID patient with a person that has received an operation and that may become COVID on top of that. This paper that was briefly shown by my colleague before, by Ruben, is really just a multi-center survey which looked like really at the increased burden on healthcare system and how would that work in terms of limited resources with the availability of transplantation. And they came up with this new four-dimensional model of quadripartite equipoise, really to balance also ethical issues and ethical tension. And it's a fluid, dynamic model that, depending on, is based on donor graft safety, waiting list mortality, and really can look at the availability of healthcare resources in that moment, and therefore give greater availability for transplantation if possible. In terms of recipients, we already discussed the prioritization. We do not want to use marginal livers. We only want to use good livers to avoid patients needing filtration after transplants and prolonged ITU stay. These patients really want to get in hospital and get out as quickly as possible. Of course, they get a swab beforehand, and they get a BAL at intubation. We need to make sure that enough blood products are available, because of course during lockdown, less people have gone in donating blood out of home. There needs to be availability of resources, particularly health courses, ITU beds, and as we said, prioritization is those with acute liver failure, those with very high MELDs, and possibly those at high risk of malignancy that cannot have another TACE or another sort of bridging maneuver. Need to limit as much as possible radiology and endoscopy afterwards, trying to avoid patients visiting at different wards. And after the discharge and follow-up, we try to use telemedicine as much as possible and avoid them coming to hospital unless it's absolutely necessary. In terms of immunosuppression, there's no real need to change immunosuppression. So calcineurin inhibitors can be left unchanged if asymptomatic. WHO says that we better avoid corticosteroids for treatment of COVID-19. But most the management that we've seen in most papers, really, in most experience around the world, has been that of reducing or stopping mycophenolate and azathioprine, particularly in the setting of lymphopenia, which is typical of COVID and is also potentially also a prognostic marker. The other issue of treatment, I'm not an expert of treatment for COVID, but of course, well, I've tried hydroxychloroquine for a while until the Lancet and New England paper came out, and now they're saying that it's good again to take until the trials are finished, and trials should resume shortly. But there is no known effective treatment. There is therefore uncertainty on what are the best treatment strategies. From our point of view of transplanters, we need to avoid interaction with immunosuppressants. In terms of group of patients that have been studied after transplantation that have acquired COVID-19 infection, the ELTR and ELITA, so the European Liver Transplant Registry, looked at, and it's just been published the 4th of June, sent out survey, and 114, so 77% of centers replied, and half of them had at least one case with COVID-19. And in terms of symptoms, the typical symptoms: fever, cough, dyspnea, diarrhea. Well, these are all symptoms that you can get after a liver transplant. So we need to be really alert of the possibility of developing COVID-19 in transplant recipients. In terms of comorbidities, the most often seen were BMI, hypertension, and diabetes. In terms of treatment, hydroxychloroquine was the most used. Now we hear that lopinavir, ritonavir is probably not effective, and azithromycin is also not used as much. In terms of mortality, the interesting data is that it was great. It was about 16% greater among males, among patients above rather than below 60 years, almost no death less than 60 years of age, and of course more in ventilated patients and more in patients transplanted over 2 years ago. In terms of mortality, again, there's been initially a paper from Milan, from Dr. Bori and Mazzaferro, looking at 6 COVID-positive liver transplant recipients out of 150, and seems that on this small cohort, they postulated that patients that had been transplanted more than 10 years ago were more than 65 years old, male, BMI, overweight, with hypertension, diabetes, were at greater risk of death. But actually, this other paper letter posted published by The Lancet looked at 2 databases securing COVID-Hep with a significant greater number of patients, and we looked at 39 liver transplant patients with COVID-19, and they observed, as you can see on the left, that frequencies of comorbidities were not different between fatal and non-fatal COVID-19 cases. So the effects of COVID-19 on those with liver disease or liver transplant, it still remains unclear. In terms of, and I'm concluding, in terms of protection, of course, minimum staff in theater, we need to have the appropriate PPEs, but I warn you, I had to use it a couple of times, and it's difficult to go over 2 hours with a full PPE in place. I took it off. It's also very difficult to take it out correctly, and you take it off, and it's like if you had a shower, because you cannot, there's no perspiration. So every task is slower and difficult, and so I can, team changes may be needed in if you look at longer procedures. And I think PCR testing should be done, weekly, at least in healthcare workers, and that unfortunately is not the case. And I mean, I speak for myself, but I had it done. I had 1 blood tests looking at antibodies and 1 PCR testing, because I came in contact with a potential COVID positive patient who wasn't actually COVID positive at the time. Hospital in US, UK, and Europe have discouraged doctors initially from using masks and basic PPE. I'm not sure whether they didn't have them, and therefore that there was a discouragement, but also in Italy, I've heard of episodes like this, and they really upset me, because we're not looking at upsetting patients. We're looking at protecting patients, because we know that with a mask we are protecting them more than protecting ourselves. And so in terms of if we have a high risk contact, at least where I'm working right now, if you are anyone else, you go home. But if you're a medical worker, you have to go to still work under surveillance. But a sick doctor is no longer a resource. So I think we've been really, at least at the beginning, used without being given adequate protection. And up to a few days ago in Italy, coronavirus had caused death of 163 doctors and 40 nurses. As you can see here, is another example of someone who's been suspended without pay for what? For wearing a mask. And on a good note, this is Dr. Cato from the US. It's a famous liver surgeon who's been 2 weeks on a ventilator and has been 4 days on ECMO and has managed to get out alive. And I'm glad for that. So there are still many unknowns. We have to acknowledge that there is limited data, and so we hope that we base our management on expert opinions, on registries that lack granularity, on single-center reports that are too small to deduct any conclusions. But I think as we get more experience and better data, we'll improve our management, and we'll end up also understanding the costs. We're looking only at deaths related to coronavirus, but actually there is all the hidden deaths due to the fact that we have not done operations for cancers, we've not done enough transplants, and you can see in terms of these curves in terms of number of transplants and numbers of patients on the waiting list to cross over and having potentially more patients dying on the waiting list in the future. And I conclude with this, that it's good to have more data, but we may be actually overwhelmed by the data that we're getting on COVID. So we reach more than 23,000 papers, and it's doubling every 20 days, worse than a cancer. But we hope that we get good data for the future. Thank you.
Ruben, do you want to become the chair? Then I can start talking.
It will be a pleasure. So Faisal?
Pfizer.
No,
Pfizer, is it still okay?
Can you hear me now?
I can hear you, Faisal, now.
Excellent.
Okay.
Can you hear me now?
Yes.
Yeah. Okay.
Okay, thank you very much, Professor Paolo Muzan, for giving us such a nice presentation. And now it's my pleasure to introduce Professor Mohammed Rela. Actually, he doesn't need any introduction, but I'm obliged to say a few words about him. I think me, Ruben, and even Professor Muzan, we are all students and have learned the skills of liver and transplant surgery from Professor Rela. And this is now a new time to learn something, how to do living donor liver transplantation under the COVID impact. I think at a personal note and from the whole Pakistani nation, we are all indebted to Professor Mohammed Rela because he was the one who helped us taking us through the first phase of starting liver transplantation in Pakistan. And Professor Rela, thank you very much. And now I think there are about 7 to 8 transplant centers in Pakistan doing a decent amount of work with, I think altogether, probably we are doing about 500, 600 transplants per year in our country. So slowly and gradually, we are also trying to contribute to the literature. So this is a high time that we have to change our practice about living donor liver transplantation. All the registries and different liver-based organizations are trying to stop living donor liver transplantation because by and large it's an elective procedure and carries a risk to the donor. But actually we don't have any other option here. In Pakistan, diseased donor organ transplant does not exist. And that is what we are looking forward from Professor Rela's talk, that how we can come out of it and what are the strategies which we can adopt to carry on living donor liver transplantation safely. Professor Rela, I hand it over to you. Ruben, can you do something?
I had one ready.
We could start some discussion until Mohammed is back on.
Yeah, I think that.
Yeah.
Yeah.
Dr. Zayab?
I mean, Ruben, how is it the situation now in Spain? Have transplant centers resumed the normal activity, or you're still in? Because your wave was approximately two weeks after ours. Okay. Oh, I see, Mohammed.
Yeah.
Professor Rela, can you hear me now?
Faisal, is there
Yeah.
anything that you can do for
Yeah,
unmute?
I can.
Oh, here it is.
I've unmuted. Can you hear me?
Yep.
Yes, we can. We can.
I'm sorry. I think my internet, this is Indian internet. Tell me if you have a problem when...
No, we can hear you well now. And
okay,
you
and
can
you can see my slides too?
Yes, we can.
Okay. I'm sorry about that. We lost about 2-3 minutes to reconnect. Now, I was fascinated really by the two talks. Is Ruben still there?
Yep, I'm here.
Yeah, you're here. Really, I have a lot of questions for you guys, but I'm just going to touch a little bit of what's happening in India and then what my personal experience has been rather than go through everything else. And what we had to go through, it might seem very primitive for you, the two of you guys from UK and Spain and Italy, because you've seen huge number of cases. For the Indian population, the numbers have been quite small. So even though India is ranking number 6 in the world with yesterday's statistics of 226 million and 6,340 deaths, the mortality has actually been quite low in India. But it's always a worry that the numbers may not be very true. But India is one country which went on a very early lockdown, went on a complete lockdown. Probably 1.3 billion people went on a lockdown in contrast to China or even Italy, where the lockdown was only in the northern part initially. So it really scored 100% in terms of the scoring system for effectiveness of lockdown. Maybe that is why we keep talking about flattening of the curve, even though the numbers may sound a bit high, but again, for the population, I have to say that it's not huge for India. This is just to show you in comparative terms. Guys, I don't know what's happening. Yeah. So Ruben was saying about elective surgery and the worries about surgery. We had a huge concern, and as you can see, the elective surgery is all significantly reduced. I'm having difficulty, guys. I don't know if it is my... Can you hear me?
Yeah, we can hear you well.
Click on the screen, Mohammed, not use the keyboard.
Click on the screen.
Yes.
But I can't see my... Yeah, okay, great. Oh, that's very good. So every country really went through different phase, and what was interesting from this I see is the UK resorted really to the private sector to do some cases. That is what I understand, at least in London. They took the help of the private, and the UK numbers, as you can see, went down dramatically. Ruben was talking about 3 pillars, and this slide is somewhat similar to what Ruben put up. And one of the concerns we had was really, there was, even in the postmortem findings, they said there was presence of the viral particles within the liver, because at least the biliary epithelium has got the angiotensin expression of the angiotensin converting enzyme. So it was meant to, the liver was meant to have the viral particle within it. In the early days, obviously now it's changing. We had worries about immunosuppression and COVID. And most of what we were seeing earlier on was the risk of transmitting from a DDLT to a recipient. But it's much worse if a donor in an LDLT gets infected postoperatively, because we saw that getting infected, even for elective surgeries, patients getting infected. I think Ruben said about 50% or 30% of them developed serious chest complications with a mortality of almost 20%. So this has been one of the biggest concerns for living donor, and you could see that most of the European countries stopped doing living donor liver transplantation for that period. Now there has been many, Paolo also showed that there have been many recommendations for a usage of deceased donor, most of which saying that the donors, potential donors should be screened. The time has always been an issue. In the early times, we almost took a day to get a result, and it wasn't really practical to do. But in India, really, the organ donation completely stopped during the lockdown. So at the moment, even in Chennai, actually, we have not done disease donors for the last 2 months. There have been some activity in the northern parts and in the southern part. But I'm just going to talk about really our experience of the time and period and what happened. Paolo was there in India at the end of February. We were really worried if Paolo was going to bring COVID into India. He arrived from Italy at that time. So when the meeting finished, we had a large number of patients to do. If you see the longer bar indicates 2 transplants in 1 day, and the shorter bar indicates really 1 transplant in 1 day. So we were happily operating 2 living donors and 1 living donor each day in the month of February until really the middle or 17th or 18th of February, when the WHO declared a pandemic and India were talking about lockdown. I was seriously concerned about continuing the liver transplant program, the living donor liver transplant program. So I thought I should stop for a week and see what things look like. That is what I did. So in the early period, I think there were about 15 transplants done in the first 2 weeks of March, and then we stopped just to see what happened. But then recommendations came, which was a little bit aggressive. I think in India, people go a bit aggressive. The Liver Transplant Society of India stopped all elective operations. They said you cannot do elective liver transplants. If you had acute liver failure or acute on chronic liver failure, you could do, and therefore, from that point onwards, it wasn't possible for us to do. They only allowed really transplants for acute liver failure. So this is what it is, and so we had to really communicate within our own people to say that there are a number of patients who have worked up and the recipients were getting sick, and we requested that we restart the program. So in the month of April, I think it was on the 14th of April, really we stopped for about 3 weeks with doing nothing. We did, not on the 14th, sorry, we restarted around the 7th of April and did 5 transplants. The procedures, I mean, I was surprised when Paolo said the doctors were not allowed to wear masks. My daughter working in the UK also said that people really, I think that the rules were made because of availability or lack of availability in the UK at that time, I think, or in Europe, because people thought doctors wearing masks in other places than it's required meant it was a wastage of resources, and therefore really they banned people from using PPE, I think, which is completely wrong. And it's very shocking really to see so many doctors die in Italy as a result of this. So we happily restarted and did 5 transplants. We were always worried, and then on the 6th transplant, we had an acute Wilson's. The mother was completely asymptomatic, and she tested positive. The asymptomatic donor during the workup tested positive. Now, 2 things happened at the same time. We had 2 patients with subacute liver, not subacute really, acute on chronic liver failure, who was ventilated in our liver medical ICU, who turned positive after they'd been in hospital for 4 or 5 days. Now, we did not do COVID tests routinely before admission. Now we do for all patients. Anybody coming into hospital for investigation or anybody coming into hospital for any procedure, even a CT scan or an MRI now get the RT-PCR done before they will have the procedure done. So this was really early times of our understanding. Now, 2 patients, so there was 1 donor who was positive, two of the recipient who were being worked up for transplant became positive in hospital, and one of the recipients' wife also became positive. So in our setup, there were 4 patients positive. In India, we did not have. In Chennai at that time, the total numbers that we were getting each day was probably around 100 cases or 50 or 60 cases at that time. Now we are getting each day around 1,400 cases each day. So now the government really came on a, really got worried about our hospital. They thought this was the hot spot. They thought the doctors were the ones who were giving the patients COVID. So they must be contracted as a hospital-acquired infection. So we have what is called Indian Council of Medical Research, who's controlling all of these activities. They came into the hospital. They stopped us from doing anything. All elective surgeries were stopped, but we always had the post-transplant patients within our unit. Fortunately, they did not talking about shutting our hospital, because at that time the mood for the government was, if any patient tested positive within a hospital, they'd shut the hospital. Everywhere else in the world, they were talking about shortage of hospital beds to bring patients in, whereas in India, at least I think in most parts of India, even in Bombay, they were shutting down hospital if there were positive cases in the hospital. Now they've realized that's a foolish thing, that they don't, but in our case, they did not shut the hospital down, because there is no way we could have transferred all our patients out of our hospital to another hospital. So we went through, see, one of the worries for us also was, so they wanted to test almost 200 people who came into contact with these 3 patients. Now, we thought somebody's going to be positive, obviously, because they were looking after a patient in intensive care, not knowing that they were COVID positive for 4 or 5 days. But fortunately, all of the over 200 staff, I think maybe 210 or something like that, who were tested, were all negative. That was a huge surprise for me. That's probably because all of our nurses anyway in ICU are wearing masks and gloves and aprons and cap and everything. And actually that protected all of them. And that actually gave me a huge confidence that if we have a proper PPE, we should be able to restart. But this whole process of shutting down, testing everyone, putting a whole system in place. So we actually were also a designated COVID hospital, because the government wanted private hospitals also to allocate about 20% to 40% of their beds for management of COVID. So we had to take in, currently I think we almost have 70 patients in our hospital, and about 12 ventilated patients, not 12, I think there are 12 in ICU, about 7 ventilated patients in our hospital. Now we had to actually separate, physically do some really construction work or partitioning work to, fortunately our hospital, even though it's a single building, it's got a separate A&E entrance, another additional entrance, and the main entrance in the front. So we kept the non-COVID hospital physically and completely separated, and all the staffs were all separated. And we started transplanting once again. See, I don't want to go through this, and most of the existing patients who have had a post-transplant care, we went to their houses or where they were staying and took blood. We didn't allow any of the patients to come into the hospital, even though there was a physical separation between the COVID and the non-COVID hospital. Now currently we have even made it stringent because my worry, the biggest worry for me is a living donor contracting COVID after a hepatectomy. So what we do now, I said that every procedure they have to have a COVID test done if anybody is coming in. In these patients, before we start the workup, they have a COVID test done before coming into the hospital. And then the workup starts, and the whole process probably takes about 2 weeks' time. And then we set a date for the LDLT. And then 5 days before the transplant, we do a COVID test. And then 1 day before the transplant, we do a COVID test. So the 2 tests done reduces the false negativity significantly. The first test done before they come into hospital is really to prevent them coming in if they were positive. But really the second and the third test done is to reduce the false negativity so we don't land up having a patient post-transplant who's testing COVID positive after the operation. And we also actually do a chest CT. We have seen many patients who have got chest CT findings who are actually PCR negative, so we can postpone those patients as well. So that's been the policy. So this is how it went. Early March, we did 15 transplants in a row continuously. On 4 days, there were 2 transplants. And then India went on a lockdown. We ourselves stopped because we were worried, not knowing what to expect. And then I restarted the LDLT program, thinking that this is an essential thing, and negotiating with the government, and said that there are many patients who are likely to die if we don't. The 5th patient, the donor became positive, 2 other patients, and then we shut down. The government really shut us down. And then we put the whole thing, rearranged the whole thing and changed the policy. And then we really restarted. I think, when did we restart? 12th of May, we restarted our program. I think we have done about 14 liver transplants now. So things are going okay now, and patients are going through without any problem. We have not actually tested. So they have 3 tests done preoperatively, but we have not had any tests done postoperatively. But there was one patient whose chest X-ray, the recipient looked a little bit like a COVID chest X-ray postoperatively, even though he was completely asymptomatic, which made us worry. But 3 RT-PCRs have been negative, and we have discharged the patient. So it's not been a worry, and it's good to know that patients, post-transplant patients, probably don't have a severe illness if they do. But my worry is the donors. Now, in order to complete the cycle, I want to say the 12th patient with a donor who's asymptomatic, who came into the hospital, just the test done, the 3rd test done, just before the day of the operation, became positive. For the 12th, this time during this numbers. And so we had to postpone that operation. But this time nobody came to us and said it's a hospital which is giving, and because we were well prepared and we were a COVID treating hospital as well. So things have gone well because we have taken care with all of that. So that's all I have to say really. Liver transplant has to go on. Not just the deceased donor, living donor liver transplant will go on. One of the worries, as Ruben said, is if it doesn't go on, the impact is huge, and the mortality, also the cancer is an issue. I think when we emerge out of, at least in India, when we emerge out of the COVID era, there is going to be a number of cancers which are going to be diagnosed very late, and it's all going to have a huge impact on the long-term survival of patients. That's all I have to say, but what I would like to, I'd like to know a little bit more from Ruben and Paolo about how they take the whole thing. But maybe you might think, we are still dealing with small numbers. But I believe that India, maybe in 1 month time or 6 weeks time, will be the leader in the world. We probably will have the largest number. We might overtake United States, but that is where we are going. It is a worry. The lockdown is actually lifted. Stop sharing. We were all locked down when there were actually no cases at all. But now they're slowly lifting the lockdown and the numbers are going up. So it's going to be really a delayed. It won't be even flattening of the curve. It's going to be a rise very sharply from now on. I don't know if Pakistan is also in a similar situation. I'll leave it to Faisal, and then I will have a few questions to ask Ruben and Paolo.
Thank you very much, Professor Ella. I think Pakistan was also very early to start the lockdown for the first 4 weeks. And after that, they eased off the lockdown, and now the lockdown is completely over. And now, actually, we are getting more and more cases every day. And I think our numbers are going to probably increase. And what we are expecting is by the end of June, probably we are going to achieve the highest point in the COVID trajectory. Coming back to living donor liver transplantation, um, I think we are pretty much doing the same thing as you are doing. We do COVID at the time of assessment. And what we have started to do is we are admitting patient, both the donor and the recipient, 48 hours before the transplant. And on admission, we are going to take their history about contact and symptoms of the COVID. And then we repeat their COVID on that day and also an HRCT. And actually last week, one of our donors, his COVID was negative, which was done about 3 days before he was admitted. And on the same day of admission, his COVID was again negative, but since we adopted to do a HRCT as well, so there were peripheral infiltrates consistent with COVID on a CT. So I think doing a HRCT on the donor is a very good idea. So that is one thing. The second thing is we have a kind of a little outbreak in our ICU. One of our ICU staff was tested positive. He had symptoms, he was tested positive for COVID. And then we did the screening of all the ICU staff. So in the first go, we did screening for 40 staff members. And out of them, 11 came positive. And they were all asymptomatic. And then we have to do another 150 tests, including the staff on the ward, the coordinators, the doctors. And thankfully, out of 150 more tests, there were only 2 more positive. So there are a lot of asymptomatic COVID patients. And I think the donors, the living donors should be treated the same way. So I think doing COVID on the day of admission, admitting them 48 hours before the transplant, actually you are kind of isolating them so they are not exposed to their family, because most of them are taking these virus from the community and coming to the hospital. And then HRCT for those who are absolutely asymptomatic and their PCR are negative. So that is what hopefully is going to help us. And now
we actually isolate them for 5 days. You know, I told you we do 5 days before the operation and one day before the operation. Between those 2 tests, we keep them quarantined. We have a hotel within the campus, so they stay there. They don't actually come out and meet up with people. So I think maybe 2 days is also not enough, because if they have come into contact with someone 4 days ago, 2 days is not enough. So even they actually require maybe even 1 week before the operation, they have to be isolated.
I mean, isolating, we can make sure they are not in physical contact with anybody else within the hospital. But outside the hospital, it is very tough, you know, how you are going to make sure that they are absolutely in isolation.
Is there any literature on donors having it post-op, developing it post-op? Paolo or Ruben, do you know? I know there have been post-op, I mean, in the Paolo's paper was talking about liver transplant recipients becoming COVID positive and the outcome. But I'm talking about, are there much immediate post-op liver transplant recipients becoming COVID positive and what their outcome is?
There was something that was very small, and I didn't really look at it in depth, but there is not really much literature on this. But, you know, there is a recent paper coming into general surgery, really, showing that there is a little bit more mortality. Personally, I had, at least in Florence, where I'm doing a sabbatical, I had 3 cases of post PPPD, head of the pancreas resection, becoming positive. And I even had cases, and they survived. And I even had cases, as you mentioned, Mohammed, earlier, which are patients that develop simul-COVID CT chest appearance, so ground glass, which we investigated with 2 or 3 swabs, and then ended up doing a BAL because we were getting negative results, and these look typical. So there is also a paper on this, on simul-COVID pulmonary disease, that is probably viral pneumonia that we didn't pick up early before because we were not doing so many CT scans, and now we are doing CT chest scans, and we're picking up also simul-COVID chest features. So at this time, I don't think we couldn't tell donors, but prospective donors, what would be the added risk if they developed a COVID after donation. But so we didn't have really a lot of data on that.
Dr. Bilal Hamid is a hepatologist at Ucsf. Professor Elahi probably want to comment on your question. Can the admin unmute Dr. Bilal Hamid from Ucsf?
Dr. Bilal, is he there?
Yeah, hi. Thank you so much. It was such a good learning experience for me to understand. And a few things, I think this is the time that we learn from everyone and each other. So at UCSF in San Francisco, although California was hit, somehow we were not hit as much, and we continued our disease and living donor transplant. But your point is such a valid that although we're not doing high risk resolution, but we just had a patient who was in the hospital. We had 3 COVID test negative. She was scheduled for living donor. On the day of it, she had a positive one, and but the repeat one was negative. So I think now it's also this question about the false positive and false negative, which is making a lot of confusion. But your point about asymptomatic is that we had about close to 9,000 patients who coming admitted to the hospital for procedures or any admission, and we only had positivity of 0.4%. So, it is encouraging that, although we have, but we have to keep a close watch on it. And so my question is that, this 5 days, which you are putting your patient in the hotel, is it like paid by your hospital, or who is if the patient is paying? Because our insurance companies will never allow. I think we are very limited by it. It's a great idea if we can do it, because our thought is our patient may got exposed within 3 days when they were at home, which you brought up the good point. So who is paying for that 5 days admission?
It's actually self-funding. If it is insurance, because we have some government insurance which won't pay for it, but we absorb that cost. We have to absorb the cost as part of the transplant package. But if they are self-paying patients, then they pay for that. It's not very expensive in India to stay. I mean, you'll be surprised. It's only about 5,000 rupees in Indian terms for a room in this place, or 4,500. So it's hardly, when you think about the cost of the whole transplant, putting them up for 5 days is not a huge problem. So you said that out of some large number of procedures, if less than 1% were positive, but actually it depends on where you are in the world. So the number of, I think when we do tests for patients who come for routine procedures, probably we are getting close to 5% now. So it's a reasonable number of patients who are asymptomatic coming for other procedures who are testing positive. Everything depends on the prevalence. And Chennai city, where I am, is the number 2 city in India at the moment. So we are getting, I mean, compared to European countries, I'm talking about one city, we are getting around 1,000, 1,200 patients per day now. at this time in our city. And that is, we don't even know if we're testing everyone.
Professor Ella, there is a question, I think it revolves around the same discussion. It's from Dr. Faisal Hanif, he's a transplant surgeon in Lahore. His question is, how can a hospital defend or justify if a living donor develops COVID-19 infection after the surgery, especially if he was negative before the surgery?
That's a good question, actually. I think that is what we were really worried about. I really don't know the answer to that. Maybe we can't. If that's why I asked if there is any patient anywhere in the world who's become positive after the operation, so we know what the outcome is. Either that, or if you extrapolate what they have done in general surgical practice, even if the mortality is 10% or 5% or 1%, in fact, you can't go on with it. But it looks like most of the Eastern countries have restarted their programs without any great difficulty. Hong Kong, China, really Korea, and everywhere, Japan, they've all restarted their living donor liver transplant programs. And I've not had any reports of serious consequences in the donor. So, because we are so dependent on living donor liver transplantation, we can't really shut thinking we can't justify it. If it happens, what do we do? We don't even know that if it happens, it's going to be a disaster. So I have no answer to that. It's a big worry for me, but we have restarted, and so far things have been okay.
Thank you, Professor Ella. There is another question from Dr. Kazi from Toronto. And he says that, what's the visitor policy in your center? At least it's zero visitor policy in Toronto, regardless of the COVID, non-COVID patient. And can we implement all that in Pakistan or India?
We have a single visitor for a patient. So we have a one visitor policy. And that visitor also gets a COVID test done before they will enter the hospital. So we have one visitor policy.
Ruben, you want to comment on it?
Yeah, well, in our hospital we try to make it one visitor, but we don't test the visitor. So I think that's a big deal. That's a big deal. I'd like to say something regarding the manuscripts that have arisen the risk on surgical patients. I'd like to remark that most of these studies have been done on urgent emergent surgeries. This is important. This Lancet paper, which Professor Rela was commenting, in which 50% of the patients developed postoperative pulmonary complications and 40% of them died. It's in 70%, 75% of them were urgent on emergent surgeries. I think it's a completely different scenario from the perfectly studied, double-tested living donor. I think it's a really different scenario, and I think we should keep that in mind, because it's not the same situation. And even if you test the accompanying person, double test the donor, I think that the risk is really reduced up to zero.
Can I ask a question to Ruben? And thanks for that anyway. Now, are there issues with blood donation, blood transfusion, because the virus has been found in endothelial cells, even in the lungs? The principal damage and the cause of microthrombi is damage to the endothelial cells. If the virus is found in the bloodstream within the endothelial cells, where is the safety of blood donation and blood transfusion? Because we are talking about, worried about transmitting from donor to recipient. And I can understand the worry is because the liver's also got receptors for the virus, and therefore actually the viral particles can be within the hepatocytes. I think it has been demonstrated in postmortem findings that there are viable viral particles within hepatocytes. But what is people's understanding of blood donation and blood transfusion?
Yeah, I think that's a very important question. That's why I showed a slide showing that, although I think that it's not now at the moment, there are some groups suggesting to use in the future SARS positive recipients, because that concern on donor to recipient transmission is under debate. It's not really clear. Actually, there is no evidence about that, because at some point we all just drop our transplant programs. And as Paolo said, as far as I know as well, there are no reported donor to recipient transmission. So I think that even though we now we should be cautious, I don't know what would be the evidence in 3 months' time. Maybe in 3 months' time we find out that that risk is almost inexistent, you know? So I don't know. What do you think, Paolo, about that?
There is a paper I was looking now on a single case of COVID-19 transmission and blood transfusion from Korea. With 7 million patients with the infection around the world, and probably it's 3 times as much because we don't test everyone. I think it's much less than what you would expect even by now. So it's difficult. But going back to the previous issue, in this there is this Lancet paper which came out on the 29th of May on COVID-19 patients undergoing surgery and increased this risk of postoperative death with 235 hospitals, and it's actually coming from Birmingham, not from my unit. But they report an extraordinary and almost unbelievable 30-day mortality. On elective surgery, 18.9%, emergency surgery, 25%, minor surgery, appendectomy and hernia repair, 16.3%. And but I feel that again, when you have so much data then from so many centers, it can't be as granular as you need it to be, and you don't know all the risk factors that are involved with this. So I think we need to know better. As you say, in 3 months or 4 months, we'll have probably better data to understand if there is. It is likely that there would be an extra risk, but I struggle to believe that it would be that high. And in Europe, you may confirm that, Ruben, maybe or not. There is the feeling that some politicians have sent the wrong messages here in Italy, but the feeling that the virus is losing power and is becoming less infective or less virulent, and we're seeing more asymptomatic infections than at the beginning. And certainly we have less patients in ITU battling for life. So it may also be that the virus is just slowly going off.
Thank you. I think just last 3 questions. One is from Dr. Rajesh, and he's asking the speakers about considering a living donor who was tested positive, but after 28 days of isolation, he's negative. When would be the timelines to reconsider him for a donor hepatectomy? Would you be happy after 2 weeks?
Well, I had a similar issue with a patient that has been positive for 2 months. I sent him to another center to do this is a cholangiocarcinoma. Send him to a different center to get a diagnosis with endoscopic ultrasound, and he got COVID in that instance, and he remained positive for 2 months, and he was desperate to be operated. as soon as he repeated the swabs every week. As soon as he was good to go, of course, he was partially symptomatic or asymptomatic. We went and did him. So actually, he tested negative twice. He said he tested negative once, then positive again. Then we had 2 negative tests because we do 2 negative swabs, and finally we could do it.
Professor Ella, you want to say something?
Yeah, I think I know what. I turned that donor down permanently because that is the donor, fifth donor that we had in the first phase. The child was holding on actually, and we transplanted with the aunt rather than the mother. Now, the reason for that thinking is that gentleman asked, how can you justify, I don't know who it was, doing these operations? That's the sort of thing that goes through my mind. One of the concerns I have about this disease is that we don't know much about it completely. Turning negative may not necessarily mean that the virus is eliminated. Absence of symptoms does not necessarily mean that the virus is eliminated. A stress of a big operation like a donor hepatectomy may reactivate, may not reactivate. We don't know an answer to that. If the virus has an attraction for the biliary epithelium, I'd like to know really. When Nigel actually told me that he did a living donor hepatectomy on a patient who was positive, and 4 weeks later he actually did the operation, and the patient's done well. So I've got so many unanswered questions that people don't have an answer for. Just because the patients become asymptomatic, just because the throat swab are negative, I believe doesn't necessarily mean that they're clear of the virus, because there are patients who come back with symptoms after 2 weeks and 3 weeks. And therefore, I was not willing to put a living donor through that risk, which is why I said no to that permanently.
So can we do the serum IgG if that donor has attained immunity?
Anyway, we didn't have that available, so maybe I would have considered that, but antibody tests are still not available in India.
But I think.
But even so, sorry, we don't know whether you can catch this disease twice either. So it's even IgG, we don't know fully what it means, if you're really immune or not.
Professor Zagam Abbas, who's the president of the Pakistan Society for Study of Liver Diseases, he had a comment. I think he should better come up and talk about it. He's talking about considering prophylactic remdesivir for the living donors. Professor Zagam, you want to come?
Hello.
Yes.
Yeah.
Can you hear me?
Yes.
I was just wondering, because we have to live with COVID. It's not going anywhere. And what we are seeing is that there is an increasing number of COVID positive patients, and our ICUs are becoming full. My only concern is that we'll have to continue our transplant activity. And in Pakistan, remdesivir is going to be available next month, I suppose. I have been told that. So what about giving prophylactic remdesivir to our donors after they have undergone surgery, donation surgery, because we cannot stop the living donor liver transplant program, and there is a definite donor risk with the surgery also. This was my only concern.
The trouble is, we don't know if remdesivir actually would prevent a patient becoming infected. Do we have that evidence? We don't have the evidence. We only know that it reduces the severity of the disease slightly, or renders them viral negative maybe 2 days earlier than, instead of 8 days, maybe 6 days. I don't think there is really any evidence that it's going to be useful to be used prophylactically. It's going to be useful prophylactically.
Professor Muzan, you want to say something?
No. I was just thinking again about the case that Mohammed was discussing earlier. And I was just going to ask if that child had been an acute liver failure, would that have changed your mind?
It actually, I made a decision knowing that. Fortunately, the child survived to get a transplant with her aunt 3 weeks later. I made that decision knowing that the child may not make it, because the child was going to die of natural causes. I do not want to venture into an area where I did not know what we are dealing with.
Professor Allah, the last question is from Dr. Tariq Ali Bangash. He's a transplant surgeon in Lahore. He wants to know whether we can, actually Tariq can be involved. Can we unmute Dr. Tariq? He can ask his question himself. Dr. Tariq Ali Bangash.
Can somebody, you have to unmute him. Somebody has to unmute him.
Hi, can you hear me?
Yes, we can.
Okay. I think first of all, thank you very much for arranging a very nice academic activity. As Professor Ella said, there are loads of unknown things which we are not clear, and especially for us, it is very difficult to start again when there was a break for about a month and a half or two, and we restarted liver transplant program again in a very sort of a style sort of environment, because there are loads of questions which are not answered yet. And if something happens to the donor and to the recipient, I don't know, as Faisal asked this question, that how will we defend ourselves? But there are a couple of questions. One is about the doing the COVID testing for the donor. Is it the Faisal way which will be more practical, that admit the patient 48 hours before and do the 2 COVID tests, or is it Muhammad Rela's one? In the PSSLD, I think they have given that if you admit the patient, do a COVID test, and after 72 hours, redo it. And if they both are negative, then proceed for the liver transplant. The first question is that which method will be okay to proceed for a living donor liver transplantation? Number one. Number two is in the post-operative settings, especially the immunosuppression. Will we proceed with the same sort of immunosuppression, or we have to keep our immunosuppression on the lower side in the period of COVID positive era? And the final thing, the third question will be the consent, like how we are going to phrase in a consent that the recipient and the donor, they both should know the severity, and if something happens, they should accept that severity. Like how we are going to phrase it for the patients. Like there are 3 questions for the panel.
Faisal, do you want to answer the first one? Hello?
I think it is always better to isolate for longer period of time if possible, but we have to be practical as well. Cost is one issue, and putting the donor in a hotel room for 1 week, I don't know how much practical it would be, but at least it will give us as the transplant team a more peace of mind. The more we retain them, more tests we do, and then negative, then we proceed.
Faisal, I can justify both, really. When you do 2 tests, whether you do 2 tests at 2 days interval or 1 day interval, the usefulness of 2 tests is it reduces the false negativity. Because if you say it's 70% positive on the first test, 70% positive on the second test, you're probably narrowing the false negativity to less than 5%. So that was the justification I had for doing 2 tests. So you can simply do 2 tests. Even if you do 2 tests at 12-hour interval, it's as effective anyway. So that is the purpose of doing 2 tests. Because if the single test was 99% accurate or 95% accurate, you wouldn't need to do 2 tests. Now the interval between the tests, I decided, is 5 days rather than 2 days, because I felt that if a patient was actually infected only 3 days or 4 days before you do the test, it's going to be negative during the incubation period, because the average incubation period is about 5.2 days, which is why I decided, if supposing in your system of doing 2 tests, if the patient was exposed, had a high risk exposure 4 days before, the test done on the second day and on the day of operation would still be negative. Whereas if the patient had a high risk exposure, 5 days or 6 days or 7 days, whatever it is, 8 days before the operation, either the first test or the second test would pick it up. If the first test happens to be too soon after the exposure, the second test is bound to pick it up, which is why I decided on the 5-day gap between the two tests done immediately before the operation. The test done at the time the patient arrives into hospital is really to protect everybody else, to know. So that is not to protect for the operation. So 2 tests done before the operation is what is important. And both are okay. Both serve the same purpose. But I felt that leaving 5 days serves the purpose of really missing out the incubation period.
And Professor
The consent, somebody else can talk about the consent. Yeah.
Professor Muzan, can you comment on the immunosuppression part of the question? Should we change or we just continue with the same?
Suppression, thank you. The immunosuppression, let's say the consensus right now is not to change much, particularly in the early post-transplant, because you don't want to, particularly in asymptomatic patients, you don't want to go the other way around and end up in rejection and needing again to move around in other parts of the hospital to get a biopsy. And but most centers have avoided or reduced the dosage of mycophenolate and azathioprine. So that it's pretty simple. There is a tendency to reduce immunosuppression, I mean, calcineurin inhibitors, in the longer term, so in patients that are already 2 years of, after transplantation. And the other thing, as I said, is to avoid, I can't remember which is the drug, one of the drugs that are used there are a couple of drugs actually that can cause interactions with the immunosuppressants. So need to be careful with that.
Thank you very much.
Can I ask one thing to Paolo, because Professor Rela saw their 2-test program and isolate the living donors for 5 to 6 to 7 days. But I think our hospitals, you and mine, are quite different from those hospitals. So how are you doing that, Paolo? How do you think that we can do it in a public healthcare system? Because I can't isolate a donor for 5 to 6 days. Or how are you doing that? Are you double testing living donors, or?
It would be very difficult. Well, I'm about to go back to Birmingham, so we'll restart the living donor program there. But I think in Europe, as you know, there's living donation is not as developed as in the Eastern countries, and is not as desperately necessary, because you have the resources of cadaveric donations and marginal livers and so forth. And so it's a good alternative. But you know, if you did it, you would probably need to rely on patients that, or I mean, donors that would be like most civilians nowadays. After 3 months of between lockdown and going back to normality, you'll have to rely on their responsibility and understanding of the situation and try to isolate themselves at home and wear masks at all times. I mean, I don't isolate in family, but I wear masks all the time wherever I go, in open spaces and public transport everywhere. So I guess you'll have to rely on that. That would be the best you could do, or go to in a hotel near the hospital if you are from another city. But here, you know, most patients come from the region, so you would have to ask them to isolate themselves.
Yeah.
Professor Ella, Dr. Niaz Ahmed, he's a transplant surgeon in Leeds, now has moved to Saudi Arabia. He also used to work in King's College Hospital. He has a question for you, that how frequently you would screen the transplant team for COVID?
Yeah. Well, I told you earlier on, we did tests on almost 200 people involved in the 3 patients who tested positive and found that all of them were negative. Yes, it is a concern that the transplant team needs to, but I'm going to say something which I don't know how many of you would be able to follow that. Currently, we are not testing the doctors, because if we test the doctors, you have to do the testing every week. It makes no sense to test the doctors. If they're symptomatic, we test the doctors. If they're, and the doctors have to do a self-declaration, I think every week or so, they have to fill a self-declaration if they've got symptoms. There is an online thing that they have to do that. If they're symptomatic, they get their test done, if not. But we do something else, which we consider every patient that we operate on as potentially COVID positive. So the doctors have not the same PPE that they have in a COVID ICU, but they almost have an equivalent PPE when they are looking after normal patients. So they'll have gloves, they'll have goggles, they'll have a shield, they'll have N95 mask. So the risk of transmitting from the nurses and doctors to the patient is significantly reduced. We may change it over a period of time. Currently, we are being very, very defensive. So the answer is we don't test the doctors or nurses unless they have symptoms. And we consider we have PPE for every operation now. So that means the cost of all the operation increases by about 5 to 10%.
Okay, thank you, Professor Ella. Lastly, I would like to invite Professor Vasim Jaffri. He is a distinguished professor of hepatology, and I would say he is a father of hepatology in Pakistan, has trained a generation of hepatologists in Pakistan. He was the founding president of this Pakistan Society for the Study of Liver Diseases. He wants to comment, and I will also request him to conclude the session as well. Professor Vasim Jaffri. Okay, then I would ask Professor Zagham Abbas to conclude the session.
Hello, thank you very much, Faisal. It was a wonderful meeting. And I can see, though we have consumed much time, but many of the participants are still there. So it makes me very happy, and I am very much glad to see so many participants in this meeting, and it remains my duty to thank everyone, Ruben, Paolo, and Muhammad for participating and sparing their time for this meeting. Thank you very much.
Okay, thank you very much. I think we should conclude, and it's the time to say goodbye to Professor Ella, Professor Paolo Muzan, and Professor Ruben Firia. Thank you very much, and hopefully we will see each other very soon at some point. Stay safe and blessed.
Thank you. Thank you, Faisal, Mohammed, and Ruben. Great to see you.
Bye-bye.